Buenas tardes. Es un placer para mí presentar al doctor Stephen Larch del Royal Papworth Hospital de Cambridge, en el Reino Unido, quien ha aceptado amablemente pronunciar la conferencia inaugural del Congreso. Su hospital es el mayor centro británico en cuanto a trasplantes cardiotorácicos y en el que se realizó el primer trasplante cardíaco del país. El doctor Larch lleva más de 30 años realizando investigación experimental y clínica en el campo del trasplante cardíaco a la búsqueda de vías de mejora del número y de la calidad de los órganos disponibles para el trasplante. It is my pleasure to introduce Mr. Stephen Larch, a cardiovascular surgeon from the Royal Papworth Hospital in Cambridge, UK, who performed the world's first heart transplant from circulatory determined death using functional assessment of the donor heart through the technique of normothermic regional perfusion. So he's a proper pioneer in the field. I must say that there's more to DCD and ex vivo cardiac perfusion than meets the eye. And some of the novel techniques that Ms. Larch's team is now implementing may be game-changing. It's a really exciting area of surgical research that may bring good news pretty soon. Stephen, please be our guest. The virtual podium is all yours.
Francisco, thank you very much for those very kind words. And it's a great pleasure to be here back in this gorgeous country of yours. I've got a deep affection for Spain. And I've been working with a number of colleagues in Spain. So it's a joy to be here. So I'm not going to speak Spanish because I can't. And I can just about work out what my title is. But I'm presenting this on the behalf of a pretty large team here at our bizarre new hospital, the Royal Papworth Hospital in Cambridge. So let's skip through, firstly, the reasons for getting excited about donation after circulatory determined death, this new opportunity for donor hearts for transplantation, and then exploring the quality of those hearts, if you will, and finally the outcome of the clinical program that we've run. And I'm happy to say that we've just published our 5-year figures, and takes us up to 79 transplants. And I won't steal the thunder. Let's press on. So I'm good. The reasons for transplantation, well, here's the survival, and it takes us into the reasons for performing transplantation in patients who've got drug-resistant heart failure, severe drug-resistant heart failure. And this is International Society of Heart and Lung Transplantation data over many years, split into 4 epochs. And you can see the latest in purple, showing yet further improvements in survival, essentially due to the first, if I can show you the first 3 months here, probably as a result of better selection and better patient preparation. So how do we make that an argument for improvement? I've put in here, just in this turgid brown line, the results of the control group from Eric Rose's rematch trial from 19 years ago, comparing these patients who couldn't be transplanted for one reason or another, either looking at their natural history or in the experimental arm, the impact of implantable mechanical devices. And we learn that in the control arm, the outlook of the natural history of this severe heart failure is appalling. And there we see it in that brown coloration. So it's easy to say there is immense value added in terms of transplantation in terms of prognosis. And if we had a reasonable measure, and had we done quality of life measures, we'd see very much the same sort of picture. But of course, the patients have to continue on lifelong, or the majority of them have to continue on lifelong immune suppressant agents. So it's an extraordinary, clumsy, but very effective therapy. And so why am I moaning? We in Britain follow Spain very closely for your extraordinary lead in organ donation. And here you can see in the blue histograms across time, the number of donors that are available and the number of transplants that arise from those donors. The fact that we've got a couple of years where we have more transplants than donors implies that you've got to be British to have slightly more than a big heart. It's a quirk of the statistics, so forgive us this strange histogram. Here, however, is the waiting list, which has continued to rise with time, and it's very distressing to see this as we see more and more people dying on the waiting list. So, working with the NHS Blood and Transplantation Authority, you can see here the number of donors that come forward. And if you're looking at Huey in red and green, we're looking at kidney and liver. Very good usage of donor organs offered. Here in brown, and rightly so, is the heart usage. And we're looking at 15% of all donation, all donors. And when we look at appropriateness of donor, in terms of age and so on, we're using only 1 in 5, which is pitifully low and well below the service demand. So we're not doing well in terms of heart beating donation, brainstem dead donation. So we were exasperated at the turn of this millennium and asked questions about what other folk are doing. And here this is a picture of age, and this is, I'm sure, much the same in Spain. Donors are getting older. That's just an aside. So here we look at the number of DBD donors, brain dead donors, on the rise, following your lead. And here, living donation. I've got a couple of colleagues I would love to put forward as living donors for heart transplantation, and they know who they are. I'm joking. DCD donors in liver and kidney have been on the rise and continue to be on the rise. So we said, why are we being excluded as heart transplant surgeons, and indeed heart and lung transplant surgeons, from donation following cardiac arrest and circulatory determined death? So we looked at the cause of folk going forward for donation after circulatory determined death, really as a result of withdrawal. We're looking at Maastricht 3 criteria here, withdrawal of futile medical therapy and a request from the relatives and from the intensivists to withdraw that therapy, leading to cardiorespiratory arrest, and the story begins there. What we see as the etiology here is essentially restricted to intracranial mischief, and that's very exciting, seeing as being parochial and worrying solely about the heart. So our stepwise assessment here, working with the Blood and Transplant Authority in the UK, we looked at 3 years data, and there are about near on just over 3,000 potential DCD donors, and we provided a guillotine of consent, age, proceed to donate or not, functional warm ischemia being less than 30 minutes, and so on, down to what our conclusion in the early stages of this work, suggesting there might be about 168 suitable donors over a 3-year period, kind of 50 for the nation. And for a nation that transplants low volumes, about 160 transplants a year, that's an enormous step up and a huge advantage. So we were excited by this. We modeled in the States, or indeed we're prostitutes. We use the States, we use Canada, anywhere we get a lab. And here actually in Stamford, we were modeling small mammals using rats and getting access to their hearts and providing anoxia for an anoxic arrest, and then resuscitating with a micro rat circuit, ECMO, to regain animation of the heart, reckoning that 15 minutes was well within the tolerable time zone of a heart at a mammalian heart at normothermia. We did that also in pigs in Winnipeg with Darren Freed, and there we were allowed to use the mass spec machine, and here we could see what happens when the heart is seen to be under control, no ischemia. And we've got very good levels of very good signal of phosphocreatine and the 3 signals of the triphosphate of adenosine. After 15 minutes of rest, I have to say, surprised to see such massive increase in free or inorganic phosphate and a dreadful diminution in phosphocreatine and the phosphates of adenosine. After reperfusion in the body, a normothermic reperfusion within the pig, this is a pig model, we found that there was some trend towards reparation of the phosphocreatine, the 3 energy stores. We weaned the heart then off the ECMO support, the normothermic regional perfusion support, and over the next 20 minutes had the heart perfusing the reduced circulation. We'll touch base on that in a minute. And we saw a return within that time to pretty much pre-ischemic levels. So we were, again, hugely encouraged by these data too. And this all follows on from work done by Ganot back in the late 70s, where using a perfused rat model and histology as an example of irrecoverable myocyte damage, the conclusion he came to was that you've got about 30 minutes of ischemic tolerance in the normothermic rat myocardium, and before you have an onset of myocyte damage. And by the time you get to 55 minutes here, we're looking at percentage of cells lost across time. By 55 minutes, that is 25 minutes later, you've lost the lot. So it's a tight window. And with that in mind, we put together our clinical program very much around Ganot's work. So an interested family who lost their 53-year-old mother were excited by our work and offered their mother the opportunity, whilst she was donating by DCD her kidney and liver, for us to perform thoracoabdominal NRP. We clamped off the cerebral circulation by dividing the arch vessels. And here we show you pressure volume of right and left. Here the typical right ventricular pressure volume, here the left. And here in our resuscitated heart, after 23 minutes of normothermic anoxia, we see a very bizarre right ventricular pressure volume loop. And here in black, a very bizarre enlarged left ventricular pressure volume loop. Giving a challenge of inotrope, we normalized those loops and saw an improvement in end systolic pressure volume relationship, that is contractility, which we found hugely exciting. There was censorship because there was some aspect of consent we didn't achieve here, or a protocol for research. We're using Addenbrooke's next door, and there was a bit of an upset. So we had a bit of a setback here and delaying the progress of this program. We, in the meantime, in our pig work in Canada, declared, of course, that there's no brainstem herniation, so there could be no catecholamine tide, and we couldn't have been further wrong. So in pig work and in our early human work, we've looked at that catecholamine tide, and it's monumental. It's about 10 times greater than the catecholamine storm seen in brainstem death. So we were surprised by that, and encouraged, however, that this storm that lasts about 30 minutes seems to be associated with an incompetence of the circulation, and therefore not the translation into cardiac damage. So we hope that that's not going to be too much of a problem. But if we look at troponins, here the troponin level of controls is low, brainstem death, the sort of levels we'd expect in our regular practice. 15 minutes of DCD heart donation ischemia produces much the same sort of picture of troponin release, but 30 minutes, as you might expect, a raised amount. So there is damage going on despite Ganot's work, but it seems to be tolerable. And is it possible? Well, actually, if you look at the history of this subject, the Barnard brothers, Christian and Marius Barnard, in December 1967, of course, used exactly TANRP to resuscitate the young female donor for this recipient Wachensky, who lived for 18 days, you remember, thought to be dying of rejection, of course, was given yet more immunosuppression, worsening the problem, the underlying problem of infection. So that history was helpful. And here with Professor Peter Simpson, an intensivist and also chair of the Academy of the Royal Colleges here in the UK, was working on the recognition of brain death, of death, I beg your pardon, through circulatory determined death. And his point was that there had to be a 5 minutes of continued cardiorespiratory arrest between the recognition of loss of pulse and then that the examination of swift brainstem testing confirmed a neurologic cause of death. Very important when we come to using the heart. This used to be known as cardiac death, mode of death, which made the use of the heart particularly difficult for philosophers. So very helpful from Peter Simpson on this. And we had a third criteria that we had to, which was there would be no cerebral perfusion, and that seems very reasonable. So armed with all of this, we put together a clinical program where we recognized these patients who hit futility, therapeutic futility, would have consent for donation, withdrawal of that support, WLST, and then functional warm ischemia when, for argument's sake, we pick no fight with the liver transplanters. They declare this at a systolic systemic blood pressure of 50 millimeters of mercury, a ridiculous measure, frankly, for a diastolic perfused organ like the heart. But we fought so many battles by this stage. We assume that the diastolic pressure with a systolic of 50 is probably much the same as the right atrial pressure. So not much in the way of a perfusion gradient, and therefore an ischemic heart. Our next is loss of pulse, asystole, as seen on the digitalized pressure display, and that is the onset of our 5-minute standby. So we stand by, hands off for 5 minutes, and then death after that neurological assessment and confirmation is confirmed, and we're then hands-on. And the issue here is the method of organ protection, and we've declared that we believe this essentially to be an ischemic heart. So the method of protection is to restore a blood supply. And that we do here. I'll try and show you. This is on the Transmedics, and we've primed it with donor blood. It's biochemically reasonable and perhaps not the best stuff to use. It's the only one we've got, and you can see here very quickly the heart is animated.
34 degrees. I'm sorry, yeah.
And I'm not sure
how high is the maintenance solution?
So
25
ml.
So
150 gas.
I'm having a little bit of trouble here on this presentation. It gives you a chance to see what's going on. And I need to...
It's really high. It's a waist chest. You can transfer? Yes.
And you can see the heart here on the
Hello?
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 Hello? I'm sorry, I got into a terrible mess here, Paolo. I couldn't turn the YouTube off. Paolo, I'm sorry, I've goofed. Shall I start from here, Paolo?
Don't worry for that. You must be continuing, and I cut on the edition of the video, and I got this part, and I'm past the video, and you must be continuing, and don't worry about that.
Paolo, I'll carry on. Pablo, sorry. And so we've shown here the method of reanimation of the heart by direct procurement, putting it on the rig and reperfusing it on the OCS rig. And here I will show you the normothermic regional perfusion. It's not going to come up, and well, let's proceed anyway. So what I wanted to show you there was reperfusion of the heart within the donor, having excluded the cerebral vessels of the aortic arch and the leg arteries. And we perfuse a circuit that's of the order of half the normal circuit. And of course, we perfuse the organs of interest within the chest and the abdomen with benefit to all. And we're pretty excited about this, but it's met with some considerable resistance. It's quite a challenge doing this, but so we then have reanimated the heart. How do we transport the heart? Well, with the method of direct procurement, we're already on a transporting normothermic perfusion rig, the Transmedics, and in TANRP, we will, after a period of time, initially an hour, and then we brought that down to about 40 minutes. We'll cardioplegia the heart, take it out of the patient, and place it onto the rig, priming the rig essentially with donor blood. And then we'll transport the heart perfused, beating, and closely monitored back to the implantation hospital where transplantation will be performed. And so what are the results of this transplantation? Well, here we've just published 79 cases. We've actually done near on 90. 8 are in the pediatric field, between 30 and 50 kilograms, the rest in adults. And here we're comparing 78 DCDs to 78 DBDs in the first instance. The cause of death is very much the same, perhaps a little hint towards slightly more traumatic brain injury within the DBDs in this particular representation. We'll go through this in a bit of greater detail. So what are the post-op outcomes? Well, we find when we look at the 56 direct procurement hearts against 19 normothermic reperfusion hearts, TANRP, we find that there seems to be a much shorter requirement for ventilation, a much reduced requirement for hemofiltration in intensive care, a shorter length of stay in intensive care, and a shorter length of stay within the hospital. And the treated rejection episodes between direct procurement and normothermic reperfusion seems to be, these are small numbers, they're all small numbers, seems to be probably within the same sort of ballpark. And I'm refocusing on this. I'm not sure why I've reproduced this. It's obviously a slide we're proud of. So looking in detail at the warm ischemic time, here we see in 85 patients, these are the adults we've done, we see that the median warm ischemic time is 34 minutes. We've got interquartile ranges around that, and the minimum and maximum display of warm ischemic time. And our belief is that if the heart is beating, there's nothing like ischemia to stop it beating. So we're not too worried until we hit a mean of less than 50. Functional warm ischemia, that is the onset of functional warm ischemia at 50 millimeters of mercury systolic systemic blood pressure. We've got a median functional warm ischemic time of 24 minutes. And our aim is to be well within 30 minutes. I'm very, very nervous at the 53 minutes there. The normothermic regional perfusion duration in those that underwent this either within the chest or all within the machine was 42 minutes, a maximum of 192 minutes. And the OCS duration on the machine at 241 minutes, 6 hours mean, and a very long period of time, near on 10 hours on the Transmedics machine, which is close to the reported maximum. And so the time of withdrawal, which is what some of our colleagues in the world use, withdrawal of supportive therapy to blood perfusion in direct procurement is longer than NRP. And this may be a particular importance between the two cases. And functional warm ischemia similarly shorter in NRP. And asystole to blood perfusion similarly also shorter. And withdrawal to death quite honestly much the same sort of time. There's nothing particularly different between direct procurement and normothermic regional perfusion. The OCS time was much shorter, and this also is of particular interest to us because we were not allowed to perform normothermic regional perfusion in many hospitals, only two relatively close to Papworth, and that's why we see a short normothermic regional perfusion time. So we have an interest in the short ischemic insult and the OCS perfusion times in terms of outcomes, if there's a difference. So we find that the need for mechanical support is about 1 in every 3 hearts, ECMO being present in 14% and VAD only in 4%. So colleagues also around the world will have a much higher dependency on mechanical support, most commonly in the form of intra-aortic balloon pumping. So treated rejection, we've seen this already. It seems to be much the same sort of picture once the heart's in place as we expect to see with brainstem death beating heart donation. And I think this isn't worth really going over. The ejection fraction comparisons are a bit spurious because there's a bit of inotrope around as we describe that. And let's skip over those. So overall survival, and this is out to 360 days, 1 year survival of the DCD program shown there in red compared to the DBD. This is our 26 patient study with a reasonable degree of matching between the cases and concurrent, of course, comparing the DCD program to concurrent DBD work. And it looks as though across the first year, the outcomes are very much the same in terms of survival. And what we see here is the picture of our 85 donors and with overall survival expressed in blue. And then our problem of the red line, which I suspect, and I'm going to put to you, is a quirk of small numbers. That is the 23, in fact, if we look at the pediatric population, the small volume of patients that had TA-NRP. We've had no deaths, and they seem to be very robust hearts and performing particularly well. A little upsetting. It's a technically more demanding procedure, but seems to produce extraordinarily good results, at least in this early stage of our work. So 4 issues really with looking at NRP and DPP. When we have NRP, we have the heart beating within the donor. It gives us an opportunity to basically look at a donor as if it was a heart beating donor. So very familiar, and we can use familiar techniques, transesophageal echo, swan catheterization, and so on, and estimate how well that heart's performing. Otherwise, with direct procurement, we go solely on the pre-withdrawal echo. And now this nation won't move forward unless there has been a pre-withdrawal echo showing no cause for concern, and of course satisfactory clinical picture and satisfactory ECG. Transmedics requires us to look at the lactates across time, and here's our experience of the first 13, and Transmedics have some fairly unreliable, I'll drop the fairly unreliable data on lactates as a surrogate for cardiac assessment and the cardiac quality and cardiac transplantability. Had we stuck to that in this situation of non-heart beating donation, where lactates, of course, start very high because of the arrest, we would have lost many of the hearts that of these 13 that we transplanted. So we're raising a particular concern about lactates, and we'll be publishing soon on our whole experience with lactates as a quality measure in those hearts we used, and of course those hearts we didn't use. So what we have done is to express concern also about those hearts turned down because of palpated atherosclerosis. And here we've put together a Langendorf machine that we've called the Morgan, in no way because my wife is called Morgan, and in no way because it gives me a bit of leeway to do this work without being beaten up at home. But anyway, here is a straightforward Langendorf machine that is specifically designed to go on the CT scanner, so we can perform CT coronary angiograms and dispel concerns about obstructive lesions if any have been palpated. And this is one of our quality standards for DCD donation. So organ usage, here when a relatively recent publication, when we don't go on a donor run, and that, to be fair, will be because there's concerns about the age of the donor or past surgery or problems with the heart specifically, but the lung procurement is here pitifully low. Kidney, liver, and pancreas. If we do go on the run, 83% of cases we come back with a heart. We generally work to believe that there's about 25% of patients who don't meet criteria after withdrawal of therapy. So this is quite an optimistic outturn. 83% of the patients we attended, we took hearts. And the lung usage went up to 15%. Kidneys not really changed much. Liver, I'd like to tell you that was a meaningful increase. Certainly we've gained confidence with our liver colleagues because they're pleased to have an ischemic liver perfused very quickly. And it seems that, as you'll see in a second, there's benefit to that. And some mild increase, probably not significant, within pancreas retrieval. So does NRP upset other organ procurement? It would seem not. And here, a publication from our colleagues over in Addenbrooke's suggesting that with NRP, we find no ischemic cholangiopathy, the nightmare of DCD livers in general, where there's a relatively high incidence of ischemic cholangiopathy, often leading to the need for retransplantation of the liver. So that's met with great enthusiasm for NRP, which is good news. And finally, the original concerns that we should not restore intracranial blood flow were met head-on by Canada as they consider DCD donation in their nation, and they wanted to be certain that there was no blood flow to the brain. So reluctantly, I tried to encourage them not to ask the question, simply accept that there was highly unlikely to be any meaningful blood flow. That wasn't good enough for them. We, of course, amputate the arch vessels, but the argument is that through tortuous collaterals, there may be some sort of intracranial blood flow. Porcine work in this area, modeling DCDs, suggests there's a TANRP, suggests there is no flow. We found in 3 human donors that the first showed no evidence of blood flow, and we assessed this by leaving open the vessels we'd amputated distally on the brain side, and saw no return at all during TANRP. In the second case, we found 50 cc's a minute, and in the third, a huge donor, we found 200 cc's a minute. So there was concern expressed. And the way around this was to, here we're using abdominal cannulation and TANRP through the abdomen. We've cross-clamped the ascending aorta, and we're cold pleging the heart. But this has to be oxygenated if you possibly can. And then we have time to amputate the vessels, leaving the distal ends free and affording drainage. So if there is any tendency for blood to flow into these vessels and be directed towards the brain, it would drain more easily back into the reservoir, as you see in this clip. And a dreadfully complicated looking procedure, but that's where we've got to in this country. And it permits NRP to continue. And the results seem to encourage us that that's something we should do. So 8 take-home points are that NRP probably results in earlier energy store replenishment within all organs. There's a chance, of course, to assess function after death, which is very important, certainly for the implanters who are going to take my persuasive arguments to implant that organ with a little bit of evidence. And it's a chance to review, as you saw, the presence of palpable coronary disease and whether it's important in terms of inducing ischemia in its own right or not. A chance, too, to assess in this with slightly less speed the presence of malignancy. And we've had to buy 2 expensive transmedics machines and throw away the organs because of subsequently identified malignancy. That if the patient had been on TNRP and we had the luxury of an hour or so's perfusion, we probably would have recognized the liver issue, the lung issue, and the renal issue that turned out to be malignant. And of course, concerns about organ donation. And we believe, as I said before, that the organ donation may, with confidence and experience, rise to 100 patients per year. And in our 65 million population, that's about 1.5 extra donors per million population, increasing transplant activity by 50% in the UK. A chance to transport cold stored, as the Barnard brothers did with TANRP, and we've done that on 3 occasions with huge success. The Belgians have actually, this has been co-location of recipient and donor in Papworth, but in Belgium they've traveled for I think 100 minutes, and so very good indeed. And we've done pig work to show that's a very sensible way forward, and a minimal risks implied by that. And heart donation from DCD being possible for pediatrics, and we've been down as low as near 30 kilograms, but with modifications to the OCS, and of course the Morgan machine, we're designing particularly to offer a comprehensive program of the DCD transplantation for neonates right up to full-sized adults. And it would seem that the outcomes of the DCD program we're running are very much those of DBD, and that's very encouraging to see. So it throws us to ask the next question, which is, what about ischemia? And we know from ISHLT that the ischemic period, the cold ischemic period, is very important. We shouldn't go above 3 hours unless we need to. And so saying, we find that here in Europe, we're often doing that. Not so often in the States, surprisingly, a much bigger country. And in other centers, often getting into similar lengthy periods of ischemia. So is transportation with normothermic regional perfusion going to change our attitude to this transportation time? Please note, this is not ischemia in DCD, the perfused heart, of course. So we're kind of left with this picture. We've got patients who we went to when starting the program saying, what do you want? You want to be on the list for brainstem death, heart beating donation. What about non-heart beating donation? So we're guided by the patients. And I think that the implication of this slide is very encouraging. It will be very good to throw down the gauntlet here in Secce, in the meeting today, that we should be working towards organ banking. And it's I think, something that we can do without too much extra work. And that's an exciting development for the future. So let me thank you for your patience. Thank you for the opportunity to be presenting in front of you this work that's been going for quite a while now, but with good results for a few patients. Thank you.